What's up, guys? It is Dr. Murphy with Murphy's Medicine. Thanks for joining me. We got a guest for you today. That's right, another guest. I'm going to continue with great guests that I meet through social media, through medicine, through everywhere that that we go, whether it's patients or whether it's providers or whether it's cutting edge thought leaders on all aspects. As you know, Murphy's Law is the diagnosis. Murphy's Medicine is the treatment. So today I'm here with Dan Duggar. Daniel is an entrepreneur, a software engineer. He has been on the cutting edge with HIV research, and I'm inviting him here today to talk about a wide variety of stuff that can go wrong. Because let's face it, when you have to live with a virus in your body long term, that you have a little bit of opportunity for Murphy's Law to rear its head. And so you have to have a plan, you have to have a strategy here, and so we're going to go over that today. But first, before we do any of that, I want to take some time to thank Daniel for coming on to the show. I know he is he's a busy guy. He's a busy guy, an entrepreneur and a software engineer, but also a researcher. And so he's here today from Tennessee, all the way from Tennessee. Hooray!
All the way.
To chat with us. You got it. So
Well,
here we are. So Daniel, thank you for coming on.
And thank you for having me.
I appreciate you coming on.
Yeah, thanks.
No, this was awesome. You bet.
Yeah, really
This is great. Absolutely. So first and foremost, let's talk a little bit about you. How
Sure.
did you, one of the most interesting things about what you do is that your work that you've done with HIV research. Can you tell us how you got to there? How did you get to there? How did you end up doing this sort of stuff?
Sure. So I'll go ahead and share it with you because I think it's important. But let me go all the way back. When I was born with a number of neurological conditions. I actually have communicating hydrocephalus, colpocephaly, dysgenesis of the corpus callosum, and agenesis of the cerebellar vermis. And so, I was always around physicians, neurologists, neurosurgeons, ophthalmologists. So medicine was always of interest to me. Thought of going into medicine, but got weeded out in botany, which I'm sure you would find to be ironic. Anyways, June the 13th of 2015, my life changed. And that's the day that I contracted HIV. And so I knew some science behind HIV at that time and waited the window period of 90 days. So no one else was infected. I was very cautious about my health from a sexual standpoint. Got regularly tested after every encounter. So anyways, the interesting thing between HIV and SARS-CoV-2, there's a lot of things, but one of them is all you have to do is put your trust in the wrong person and you can end up infected. And so I was introduced into care within 90 days and received an invitation to sit on the HIV/AIDS clinical trial group community advisory board at Vanderbilt. And so once I sat on that board, I started to investigate the immunomodulatory effects of probiotics. Because
Now what year was this, Daniel? What year did you start checking out probiotics?
2015.
Yeah.
So I already started to do some deep diving into what was driving the HIV infection, and of course it's microbial translocation. And so that's one of the primary reasons for my investigating the use of probiotics.
So that I think that's a really important point here, right? Our body is a walking petri dish, and it's not, unfortunately and fortunately, it's a setup to get infected with a lot of things, right? And so we've got good bacteria and bad bacteria, and we have viruses, and they all combat with each other in our body in different cell types and in different locations. And with HIV, this is something you're living with. You're living with a virus. And so your ability to fight off the bad effects, right, the adverse effects of having a virus in your body can be aided through other bad guys that are actually good guys, right? So tell me more about what you found out with HIV and probiotic utilization back in 2015.
Yeah. So, as I've been moving more into working with individuals with neurocognitive decline from disinfection, SARS-CoV-2, I've done even more investigation. But what was fascinating to me is that one of the first articles I read was a study that came out of Rwanda or Tanzania. So there was an author who wanted to investigate the use of lactose bacillus fortified yogurt in Tanzanian women who were not on antiretroviral therapy. Not only did they experience a resolution of their cachexia and diarrhea, but they and also candida infections diminished. They also were able to maintain a CD4 count that was stable. And the author said, if we were to continue this study to the 1 year mark, the CD4 counts would be almost identical to those that were on medication. So, it's really remarkable. So those are the lactose bacillus probiotics. One of the things that drives SARS-CoV-2 is tumor necrosis factor alpha, drives people to ARDS. Well, I had investigated the use of bacillus coagulans in the HIV positive population because it allows for dendritic cell maturation. Come to find out, it also is a downregulator of tumor necrosis factor alpha. And not only is that important from a lung or respiratory pathology or pathophysiology, lung pathophysiology, it also plays a huge role in neurocognitive decline because when tumor necrosis factor alpha is elevated, brain-derived neurotrophic factor is downregulated. So forming new neural connections or synaptogenesis is greatly diminished when that is elevated.
So let me just interject there. So kind of to recap where you're at and what you just dropped a lot of science, right? And so you and I can geek out about this.
Sure.
I want to recap it for the rest of the listeners. So in essence, there are studies that show, number one, that certain gut bacteria keep healthy cells that end up infected with HIV and end up dying. They keep them alive. In addition, that they reduce inflammation. And so those things are useful not just for HIV, but for lots of other chronic viral infections. And I would also posit for chronic spirochete infections like Lyme disease. So the second point you made is that if you are inflamed through a set of chemicals, cytokines like tumor necrosis factor alpha, it causes inflammation, and that long-term inflammation prevents our brain from getting our neurons, our cells in our brain, from growing new connections, from learning new things. And that's, let's face it, that's how we all learn new things. I want to learn a new way to drive home. Well, you're going to have to create new, just like you said, synaptic connections. You're going to have to connect those synapses, connect those nervous cells. And with inflammation, especially the tumor necrosis factor, it suppresses that connection. Is that what you're saying?
It does, yeah. It reduces the chemical that, or brain-derived neurotrophic factor that allows for those synapses to be formed. One of the other huge benefits to using probiotics is the resolution of leaky gut. So with both chronic HIV and SARS-CoV-2 infection, one of the things that it does first is it destroys the intestinal barrier function. So folks will call it a leaky gut. In medical literature, they'll call it microbial translocation. So you've got this breakdown of the intestinal barrier function. And when that occurs, intestinal contents make their way into systemic circulation. With both infections, the predominant biochemical that makes its way into systemic circulation is that of lipopolysaccharide. So when you have this microbial translocation that takes place, there is this constant immune system activation. It also contributes heavily to neurocognitive decline. And then you end up with immune senescence or premature aging of the immune system as a consequence of the microbial translocation as well. So that's one of the reasons why I recommend that people definitely use probiotics to try to arrest that microbial translocation as quickly as possible.
So to recap this sort of part of it, right? The gut is a reservoir for our viruses, right? The viruses come in our body, they're going to set up shop down there, they're going to hang out down there. And one of the things that they do is they increase permeability, leakiness of your gut. That's why we call it leaky gut. And you get this leak from your gut into your bloodstream, into your systemic bloodstream, and it releases chemicals, right? And so those chemicals cause all sorts of other problems. And one of the ways to reduce that is to stick with probiotics. So in this case, as an aside, right, you got COVID or you got diagnosed with HIV. These things, especially a new time through, and if you don't have good guidance or good support, these can be very Murphy's Law, right? What can go wrong will go wrong. And so one of the things that you're a proponent of, which I think makes a ton of sense, we use it for a lot of people, is a probiotic. But what you're suggesting is maybe, once the bull is out of the barn, you should still continue the probiotic, but ideally to improve your hardiness, from infection, you would say start a probiotic ahead of time. Would you say that it would make sense for the people here that are listening to us that they should be on some sort of probiotic to begin with?
Most definitely. What's interesting about both infections is that the CDC decided that they were going to come up with a second 4-H club. With HIV, it was homosexuals, hemophiliacs, Haitians, and heroin users, right?
Yeah.
With this infection, with SARS-CoV-2, it was those that have hypoimmunity, right? They're immunocompromised, hypertensives or high blood pressure, hyperglycemics or diabetes, and high BMI or obese individuals. Well, what's interesting about all 4 of those is that they all have dysbiosis or disturbed gut biomes in common. And so I think it makes total sense. We ignore the gut and the critical role that it plays in immunity. I mean, I call it the gall to salt when the virus hits your body, because that's where it goes. But the gut associated lymphoid tissues, which run from your mouth to your anus, is the largest lymphoid organ in the entire body. But we ignore it. We eat processed foods. We use antibiotics and then don't take a probiotic afterwards. And we wonder why we're in the shape we're in.
Yeah, I agree with you. There's an all-on assault from food chemistry in the United States that when you go to other nations, you don't see nearly as much of it. And in fact, it's a whole industrial complex that's led to eating processed food. I think I'm 46, and so I think about how I ate on the farm relative to how I ate after the farm. And on the farm, we did not have nearly that processed food. But when things got busy, when it was time for school, and in the 80s, we saw Lunchables or Snackables or whatever a bowl, deplorable, right? Whatever kind of a bowl is out there that we took in. And now we have a higher incidence of colorectal cancers because of this, as well as other chronic diseases, including obesity, like you just said. And so, getting your gut health right, and preparing for the onslaught that is a viral infection. That is a viral infection. I think is a very, very smart thing. So you've been doing the digging on all of this, and it seems like you've got some really key insights into it. But one of the things I really want to talk about with you, and that kind of excited me when I was on social media with you and we were talking about these things, is great. You're infected. Now what? And so one of the things that I think was very useful that you talked about, and I think it's a great corollary with HIV and SARS-CoV-2, is the following. What meds are out there, and what are the good, the bad, and the ugly, so to speak? And since you've been with us with HIV, you are certainly familiar with these other medications that have been proposed and even are used with SARS-CoV-2. So can we talk about that a little bit? Can you talk about your experience with medications?
Sure. So, we know that there is CD4 apoptosis with this condition. We've seen it in journal articles. It's now made it onto Merck Medical's website. They list COVID under acquired lymphocytopenia. And so because of that, we can borrow from what we know of HIV. And there are a number of concepts that really need to be paid attention to. And the first one is what's known as the EDS, and that is the estimated date of seroconversion. This has been studied greatly in HIV. I actually make reference to it in my article that discusses SARS-CoV-2 associated neurocognitive decline. But what they have found is that if an individual initiates antivirals within the first year of their estimated date of seroconversion, when you feel like crap, when you've got your runny nose or you've got your headache or your fever or whatever, when you're producing those antibodies, if you initiate within that time period, then there is what's known as a CD4 normalization, where your CD4 count will return to pre-infection levels. And you maintain your immune competence. Outside of that time, you will have some normalization, but it certainly won't be as great.
So can I just interrupt for 1 second? I'm sorry. Sure. I want to double check this. So what you're saying is, when you get infected the first time with SARS-CoV-2, right? Because we're talking about SARS-CoV-2 right now. If you start an antiviral, you are more likely to recover your immune response in a pre-infection fashion? Is that what you're saying?
Yes. And let me for the I know you have a wide audience here, and let me so Jason Okulitz, Okulicz, is the author of the study that I read, and it's influence of the timing of antiretroviral therapy on the potential for normalization of immune status in human immunodeficiency virus 1 infected individuals.
So this is I'm sorry. So see, there's my fault, right? So this is HIV therapy is what you're talking about, right?
So borrowing from our, 40 years of knowledge of HIV medicine, I've applied that to this virus in light of the fact that it does, deplete your CD4 cells.
Got it. So the corollary would be introduce an antiretroviral in SARS during your SARS-CoV-2 during your first year to obtain a response similar to that which has been seen with HIV. That's the hypothesis, correct?
Yes. Yeah.
Okay.
Because you mentioned the gut earlier. So the two most well-known study reservoirs in HIV are that gulf that we discussed, the gut,
Right.
and then the central nervous system. So there is no treatment for HIV-associated neurocognitive decline, and there is no treatment for SARS-CoV-2 associated neurocognitive decline. And so there's this concept, so those are called reservoirs, right? And so there's this concept that is known as seeding, reservoir seeding. And so the strategy is to prevent or militate or prevent against what's known as reservoir expansion, because you're not going to be able to reach those reservoirs, or the virus rather, in those reservoirs like you would be able to do so in the peripheral blood. So
Right.
you want to initiate as quickly as possible to prevent those reservoirs from expanding. So ideally, you want to initiate as quickly as possible, but no less than a year, or no more rather than a year from that estimated date of seroconversion.
So to me, right, when I think about antiretrovirals with SARS-CoV-2, right, I'm familiar with antiretrovirals for HIV. There's always a double-edged sword there, right? I mean, there's risk for long-term additional complications, and I've seen it with patients. Let's talk, because currently the molnupiravir has fallen out of favor, and people are really pushing Paxlovid on a lot of people. What is your take long term with those medications? Let's talk about Paxlovid. What's your assessment so far, and what's your research? What have you evaluated or come across with using these sort of medications?
Yeah, well, thanks for asking. There's a couple of things. Number one, protease inhibitors are not first-line medications in HIV, and for very good reasons. Secondly, I think it's important for us to say, okay, or to ask ourselves, okay, what organs are the richest in ACE2 receptors? Okay, when we're looking at the use of antivirals, what organs are the richest? Well, we've got the liver, and we have they have ACE2 receptors, the kidneys, and the pancreas. Okay, with extended use of a protease inhibitor, comes the development of non-alcoholic fatty liver disease, hypertriglyceridemia,
Yep.
lipodystrophy,
Mm.
and the new onset of type 2 diabetes. And so you have a population who has, impaired livers, impaired pancreases due to the virus because it uses the ACE2 receptor to infect the host. And so why would you then put them on a medication that's going to compound that? Additionally,
Wow.
everyone wants to talk about endothelial damage with this virus.
Right.
Well, ritonavir causes endothelial damage by downregulating the production of nitric oxide.
Right. So to recap that, I don't mean to interact too much, but again, when you drop the science, because you're really, really doing a great job of it, I want to catch everyone up to speed, right? So first step, when I opened our testing sites back March 9th of 2020, like the first sites on the East Coast, we did drive-through sites. But one of the things I did was I said, these patients are getting infected with a virus that's just not a respiratory virus. It's infecting their body using ACE2. So I pulled up, I did I did a simple scan on PubMed on ACE2 receptors and anatomic locations and whatever those organs were, and it scared the hell out of me, right? It terrified me. And this was March of 2020, to the point where I said, holy crap, I've got to do blood tests on these patients to monitor each of these organ systems. How am I going to do that? And so we devised containers. We had shipping containers where we were doing blood tests in open air for patients because that was the safest way to do it, right? We could go into the office, they'll spread it with a bunch of people. So we literally had tubes like shipping containers and pack rat containers where we were drawing blood on all these patients. So what you're saying is the following. ACE2 receptors are in a lot of places. The most rich ones are the same ones that the virus will store itself in and cause a bunch of damage, and that the medications we're proposing to use to eradicate virus, to prevent, viral loads going up, and to maybe help, quote unquote, treat long COVID, cause damage to those exact same organs. Is that what you're saying?
Exactly. Yeah. Yeah. And, one of the things that is of concern to me, if you look at it, this virus, essentially what it is a respiratory virus. And when it hits the body, it destroys or sets about destroying the organs required to metabolize and excrete antivirals. And so it's a virus that will, lead to the death of many as a result of that, because you can't initiate antivirals to militate against all of the pathophysiological processes taking place, because the body is incapable of making use of them. So, and you add the lymphocytopenia on top of that, and you're set up to die or to be eaten alive by opportunistic infections. So it's a serious situation.
Well, you just hit me with a big point here. I mean, calling it out like it is, and there's a lot of hyperbole out there, Daniel. But I remember in the first 2 months of the pandemic that we were receiving comments from people in the subcontinent in India, calling this airborne HIV, calling it airborne HIV. And what you're saying right now is, I mean, we're almost 3 years into this pandemic, and you're saying what they said early on that we obviously were all very concerned about. So would you say that that's the case? Would you say that this is an airborne HIV-like? Because listen, lots of viruses are different, but how it's carrying itself about. Would you call this I don't want to use the word cousin, but a relative to HIV in the way that it's acting?
Yeah, I mean, I've seen individuals lymphocyte subset panels, and they are declining. And there's so much more to a chronic HIV infection than just having your CD4 cells knocked out.
Yeah, tell me more about this so we can plan for the worst case scenarios. Tell me what happens.
Well, I mean, we have osteoporosis, which we are observing in people.
Mhm.
They're losing their teeth, their jaws are disintegrating. We have individuals that are experiencing wasting syndrome. It's one of the things that I actually ask people when I do my scan. If you are an individual who has diarrhea lasting for 30 days and a 10% reduction in your body weight, you have wasting syndrome. You're cachexic. So if you have somebody that is experiencing this and their teeth are disintegrating, their jaws are disintegrating, and the reason for that is we have what are known as macrophages in our bodies, right? White blood cells that are becoming infected. They then differentiate into osteoclasts, which participate in the bone remodeling. Well, you have an abundance of those osteoclasts in your jaw because of the mechanical stress that is placed on it. So that's the reason why people's teeth are disintegrating and their jaw is as well, is because those osteoclasts are hyperactive, and we're not doing anything to arrest that process from taking place. And so, okay, I've got diarrhea, I can't eat. How do you correct that problem? You can't unless you're going to put someone on
Right.
TP. What are you going to put someone on
Right.
TPN?
Well, I'll tell you right. That's the option, right? You get them on TPN or Creon, which could also cause pancreatitis. So yeah, I agree with you. It's that's a tough one. What
Yeah.
are the other? Tell me more about the other long term. Just and not me because you're talking to me, but really to our listeners who
Well,
may not have awareness with HIV and the long term sequelae. Tell us what we have to plan for.
so we can look at the next one. It's been described as microclots, but the medical term that's been used forever is disseminated intravascular coagulation. And I use the medical term so that the individuals that I've worked with or read my posts can go online and actually read literature about it. So the other danger to using microclots is that you lose the idea, or the idea is lost that there's macroclots as well. And to give an illustration of that, when I was putting my paper together, I read of a woman, a nurse by the name of Candace, and she was in Florida and was unable to get vaccinated, contracted SARS-CoV-2, and is left now with a leg and a half of a foot. All other limbs were amputated as a result of disseminated intravascular coagulation. And it's observed in other conditions as well, not only HIV, but also meningitis. And so if you have an individual that has meningitis, you don't try to outpace clot formation. You actually correct the issue and you treat the bacterial meningitis.
Absolutely.
you, you,
Absolutely.
you know, uh, the other danger to that is you can go from this hypercoagulopathy state where you're forming all these clots to the exact opposite, where you can't form clots, or immune mediated thrombocytopenia. That is also being observed in this virus as well. And again, it's mediated by the immune system. And so there's nothing that can be done really unless you want to try to remove someone's spleen. But you know, I tell people, hey, if you experience pain in your left shoulder or Kerr sign, you know, you need to be getting in touch with your healthcare provider, because your spleen may be enlarging and you may be moving to this state where you cannot form clots. So we've touched on osteoporosis, we've touched on coagulation pathway disturbances. Let's see.
I'll tell you what, Daniel. The thing I had clot-wise, I'll share it with the listeners, right? So I had COVID, and then just a couple months later, I had a stroke. And it was a deep thalamic stroke. So it was inside, and I regret every minute of it, because the morning that I had my stroke, so I had my stroke in the evening, I woke up in the morning, and on my thumb, I had fine punctate dots on the side with which I had the stroke on my thumb. And so I had posted it on social media to a bunch of my other doctor friends. I'm like, hey, I think maybe I should take an aspirin today. I don't know what is exactly going on. But then I'll tell you what I did. I'm a physician, right? And I was in the vanguard kind of diagnosing COVID. I blew it off. I got busy. I carried on the rest of the day. I went and I sat and watched Netflix that night. And when I was watching Netflix, I was sitting in bed. I was sitting in my duff. And I said, oh, my leg feels kind of funny. Maybe sitting on my duff, I gave myself some sciatica, right? A nerve pain from the impingement of the nerve from sitting, from being shiftless, you know, being just a little lazy. And so I rolled to try and move my leg, and my leg felt clumsy. Now, I was a collegiate athlete for a little while, nothing major. And I also was an all-state swimmer in high school. And so I said, this is unusual for me, this discoordination. And as I did that, I said, oh, this must be a really bad sciatica. Or you know what? Those dots on my thumb, right? I said, could this be a boom? The moment I said that, my arm went numb. Wow. I said, oh my God, I'm having a stroke. And when I said that, I screamed at my partner. I said, give me 4 baby aspirin and call 911. And right after I said that, my face went numb. So, and I did a hypercoagulable workup, just like you were sort of talking about. And the hematologist is a buddy of mine, and I just got our results back. And he said, there's nothing in here that indicates why you had this stroke. You have no genetic predisposition. So it is a COVID-induced stroke. And we're seeing more and more of it all the time. So I appreciate your insight into exactly what you said, not just blood thickness, but blood thinness. And we are seeing people who, just like you said, they're losing their platelets. So they're dropping their platelet counts. And so a guy like me who's on Plavix, right, I'm on a blood thinner, is a little scared about his platelet count as it goes down on the blood thinner, right? And how we track this, it requires a massive amount of blood work, and you have to be prepared for these sorts of things when you get COVID. So I'm sorry to interject. I just wanted to share that with you and with the listeners.
Sure.
Now what else? What other things do we have to look forward to here, Daniel?
Well, talking about antiplatelet therapy, I will mention too that Plavix, there's a number of antiplatelet therapies that are contraindicated with Paxlovid, and Plavix is definitely one of them. Talking about the brain, talking about strokes, I think it's important for your listeners to know that there is what's known as amyloid protein deposition that is taking place in people's brains. Amyloid, then we also have beta amyloid that's taking place. And so the consequence of that from a stroke standpoint is something that my stepfather dealt with, and that is cerebral amyloid angiopathy, or where the amyloid proteins deposit themselves within the cerebral vasculature, which then leads to a loss of integrity. And then he suffered a number of small strokes and then had a massive stroke. But I think from a societal standpoint, we have a large number of individuals who have complained of what's known as brain fog. And, we're not paying attention to the fact that, behind our economy is our intellectual capital. And so I think that's probably what I would like to draw attention to is the fact that it's SARS-CoV-2 associated neurocognitive decline. I started a company called Sandscan, and the reason for my naming it Sand is I substituted HIV for SARS-CoV-2, and there's a very compelling reason for that, and that is that Anna Pepe came out with a journal article called "Tunneling Nanotubes Provide a Route for SARS-CoV-2 Spreading." And so both HIV and SARS-CoV-2 share the same mechanism, which is the tunneling nanotube for central nervous system reservoir seeding. And so we also, like I said, have individuals who are experiencing a reduction in their CD4 count. And so I think everything is there for us to say we need to manage this as if it was HIV-associated neurocognitive decline.
Well, this is a big deal, Daniel. So again, to reiterate where we're at with this sort of contemporary thinking, what you are suggesting and what we heard back in 2020, in April of 2020, through a lot of Indian researchers on the subcontinent, was this is airborne HIV. And so what you've suggested and the evidence that you've laid out so far and what you've discussed is the fact that these viruses are acting very similar and that the long-term effects could also be very similar. And so because of that, you've created a company, and I want to talk a little bit more about that. What are you doing with this company? Tell me a little bit more about Sandscan.
Sure. So it is a multi-faceted interview process. So
okay.
Borrowing from HIV, when I perform these assessments, and I am a Montreal Cognitive Assessment rated screener as well. I mean, I went through the certification process. And we can talk about some interesting observations
for sure
that I've made with that. But I first asked them about their estimated date of seroconversion. I asked them about the cachexia or the wasting syndrome, because that's indicative of elevated cytokines, which can also lead to neuroinflammation rather. And then I built an interview, around the work of Dr. Daniel Chertow. So he is one of the authors of a paper that documented viral persistence in the body. And there was a whole section dedicated to the central nervous system reservoir. And so I took each region of the brain and I have listed out what it is responsible for. And I asked the individuals if they've experienced any difference from a cognitive standpoint with, motor learning, inability to assess risk, issues with sleep, temperature dysregulation, et cetera, et cetera, et cetera. I then move on and I ask the individuals, I do a cranial nerve screening. And so I asked them about tinnitus. I asked them if they've experienced any issues with a lack of tear production, saliva production. What's interesting is one individual did, so that's called keratoconjunctivitis sicca, when you cannot produce those tears, and xerostomia, when you can't produce that saliva, right? Well, so after the interview was over, in the notes, I said, hey, you need to be evaluated for Sjogren's-like syndrome because it's being observed in this with this virus as it is with HIV as well. What's nice to know is that it actually resolves itself once you go on medication. So after we go through this process of assessing the cranial nerves, I then do a medication screening. So the University of California at San Francisco, they actually not only came out with a study in which they examined individuals who were complaining of brain fog using the test for HIV-associated neurocognitive decline. They have actually issued guidance to individuals or providers working with those with HIV-associated neurocognitive decline as to the medications that they are to not be put on. And so we're talking about antihistamines, we're talking about gastrointestinal antispasmodic.
Okay. So time out there. Time out there for 1 second. So sure. We know with long COVID, there are a lot of proponents of mast cell activation syndrome that happens with long COVID. And one of the things that we're seeing these patients put on is antihistamines. They're getting on, and not just antihistamines, but also then your H2 blockers for acid reflux or cromolyn or mast cell stabilizers. So are you telling me that if you have HIV-associated neurocognitive decline, these types of medications, and perhaps so for SARS-associated neurocognitive decline, would be contraindicated? Is that what you're saying, that you should not be on these medications if you have neurologic decline?
Right. If they have anticholinergic properties, then no.
Got it. Okay, got it. And we'll put in show notes those types of medications. I think that's super important for our listeners. Yeah, and barbiturates. I can just run down the list. Narcotics, benzodiazepines, CNS stimulants, muscle relaxants, tricyclic antidepressants. Those are all contraindicated in those with hand, and I would suggest sand as well. So then we move on, and if they have any labs, then I document those as well. What is their CD4 count? There's a concept referred to as the CD4 nadir in HIV, which is the lowest CD4 count. The lower it goes, it's more predictive of neurocognitive decline. And so, again, initiating those medications as quickly as possible to keep it from falling too low is the ultimate goal. I also capture the CD4 to CD8 ratio. When that is inverted, meaning there's more CD8 cells than CD4 cells, that is predictive of disease progression and a moving towards autoimmunity, at least in the HIV population. And I would suggest in this one. So that's another thing we have to watch for, right? And I can tell you right now, most people that get SARS-CoV-2, they're getting a diagnosis in adios, right? And that's what's happening almost all of the time here. Oh, you got SARS-CoV-2. Oh, don't worry. By day 7, it's either better or it's worse. And if it's worse, you go in the hospital for a few days, but you'll be fine after. What? Where is the follow-up to be had here? What it seems to me like we need real multidisciplinary clinics, not just physical medicine and rehabilitation, but true serologic monitoring and caring for patients. Would you suggest that that would be a good idea here, given all these complications?
Oh, most definitely. And the people that I interact with on Twitter, I tell them you need a lymphocyte subset panel because if you look at a complete blood count with differential, it will have lymphocytes. So if you have two CBCs that you're looking at, you may see a resolution of their lymphocytes. But what is the predominant species? You don't know. Is it the CD4 population that is predominant, or is it the CD8? Well, you can only learn that by pulling a lymphocyte subset panel. So that's, like I said, one of the main reasons why I'm a proponent of having that pulled in every individual that living with this this virus. One of the
So
other
Daniel,
uh-huh.
where can I go to find you to get this type of assessment done? Where would I go? What would I do? How could I get that?
Sure. Sandscan.me is my website. And I thought, well, how can I make it easy, for people that may be living with SAND, who are experiencing cognitive impairment. And I thought, well, I wish he would SANdscan me. So
Right.
SANdscan me.
That's perfect. So
Yeah.
sandscan.me. So sandscan, SANDSCAN.me. So Sandscan me is where you can find Daniel's contact information and his assessment, which I think is really essential to anyone having quote unquote brain fog. And frankly, one of the big problems with quote unquote brain fog is you don't notice you have brain fog. And so it almost should be one of those tests that everyone has. I'm not to hyperbole it, but it sounds to me like that's where we should go. And what do you think about that, Daniel? Am I making a hyperbole, or is it reasonable to have your assessment done?
I think it's a great idea, and here's the reason why. So the University of California at San Francisco, I believe it was Dr. Appleton. She, they, like I said, they used the test for HIV-associated neurocognitive decline. So in the control arm, obviously those individuals were not complaining of any cognitive deficits. However, 70% of the control arm satisfied the diagnostic criteria for the first stage of HAND, which is asymptomatic neurocognitive impairment. And so, as one author has stated, the impairment does not have to be frank.
Yeah, that's no doubt. I think that this is an essential screening tool that we need to have. Medicare will pay for certain screenings for patients as you get older. I believe that this is an assessment that needs to happen with everyone who's had SARS-CoV-2 infection by corollary to what we're seeing with HIV-associated neurocognitive decline. And so I can't begin to thank you enough for being on the show, Daniel. So I'm going to leave the viewers with Murphy's Law, right? When the diagnosis is Murphy's Law, which what can go wrong will go wrong at the worst possible time. It seems to me that the corollary between HIV neurocognitive decline, associated neurocognitive decline, and SARS-CoV-2 associated neurocognitive decline is the worst case scenario. And the expert in investigating this is Daniel Duggar right now. I can't begin to tell you how lucky I am to have you on the podcast. So we know that sandscan.me is where to find you, but let's talk a little bit more. One last thing. Can you tell me about a time that Murphy's Law has struck you and what you were able to do to overcome it?
I guess it was with my diagnosis. That was a pretty rough experience. You know, I tested myself on the weekend. It was a Saturday night, and the first test came back as positive, and so I thought there's no way, and so I went and bought a second one. And you know, it's not been that big of a deal for me. I think had I not faced adversity from day one, because of my neurocognitive, neurological issues, probably would have handled it a lot differently. But instead, I just decided to do a deep dive and make use of the knowledge I had at the time and come out on the other side.
Yeah, the only way through adversity is through adversity, right? You can't dodge it. It's going to happen. And so your mindset, wow, what a great mindset. And I want to thank you so much for being on the show. This was awesome. Yeah, sure. What's up?
Sure. I wanted to touch base or to touch on a medication that I have talked about previously, and I just got a word that it's being investigated even more in Europe, and that's the use of Truvada.
Okay. So for our listeners, can you describe what Truvada is for those who are not, familiar with it?
So Truvada is used to prevent the acquisition of HIV. It's manufactured by a company called Gilead. And several months ago, as I was starting to put all of these pieces together, I performed or did research into molecular docking studies, which are computer-based, and came across a number of articles that spoke to Gilead's portfolio being able to exert control over this virus. So inside of Truvada are two medications, and they belong to a class of drugs that China is actually using. China has repurposed an HIV medication called Asvudine, and it's an NRTI, or a nucleoside reverse transcriptase inhibitor. So Truvada is what's referred to as a double nuke. It actually has two NRTIs in it. One of them is called tenofovir disoproxil fumarate. The second is called emtricitabine. What is really remarkable about TDF is that it interferes with the MPRO protease, the 3CL protease, and it prevents binding at the ACE2 receptor.
So are you suggesting using this as a PrEP, as a pre-exposure or a post-exposure prophylaxis?
There are individuals who have stated online that they have been on PrEP for preventing HIV and have received the benefit of not contracting SARS-CoV-2. But we don't know the length of time necessary for the tissue concentrate or the concentration in the NALT tissues, to have any protective effect. And so I never tell anyone that they can go on PrEP today to prevent HIV and not acquire SARS-CoV-2 tomorrow, because I think that's highly unethical. We don't have any real data to prove that, But going back to, we earlier we were talking before we actually went online. We could get there if we wanted to, and if we were to adopt what we know about HIV medicine, and that is treatment as prevention. So, but the big missing piece that's going to allow for this further research to happen is the lack of a viral load test.
Yeah.
We have no way of determining disease progression and treatment efficacy in those living with a chronic SARS-CoV-2 infection like we do with HIV. Nor do we have a resistance panel to see if people are walking around with Paxlovid resistant virus that they're expelling from their lungs. And so I will say that I have individuals who wanted to prevent the acquisition of HIV. They've gone on Truvada. And so with those individuals, the majority of them have had a Sandscan performed and have experienced neurocognitive impairment. The majority of them are women, as we've observed. They're Caucasian. I've not yet been able to have them screened, but I would imagine that they are MET positive. There's a gene Val66Met, which influences BDNF expression. And I would imagine those individuals are MET positive as opposed to Val positive. But anyways, what's fascinating about those individuals is that part of the MOCA test is what's known as the serial 7. Every individual that fails the serial 7, they always successfully subtract 7 from 100. But then they move to 8. They never move to 9. They never move to 10 or 2. They're always subtracting 8. And it's very fascinating.
That's remarkable.
Yeah, that's what they do. But so going back to HIV and the management of hand and applying it to this. What I've done for those individuals is not only are they using probiotics to reduce that leaky gut microbial translocation, allowing for CD4 proliferation, down-regulating tumor necrosis factor alpha so that their BDNF levels increase. We're also engaging in neuroplasticity exercises. No reason to do that.
So tell me a little bit. Are these online, or is there an app, or what are you doing to engage neuroplasticity here? Meaning, getting new areas of the brain to develop where other areas have shortcomings. What all are you doing for that?
Yeah, so there's been a number of studies that have come out. I've got one sitting over here that talks about the use of neuroplasticity and maintaining that cognitive reserve. So I was reading the study, and they are using what's known as the useful field of vision test for assessing processing speed in individuals living with hand. So I did a quick Google search to see if one was available. I'll be damned if there isn't a platform available. It's called Brain HQ, and it is an entire suite of neuroplasticity exercises.
So that's called Brain HQ?
BrainHQ.com. So I saw no reason for the individuals to engage in neuroplasticity without medication on board.
Okay.
And so I'm going through some courses, and we're, we have what's known as the functional MRI, right, where you're able to assess brain function when people are actually doing something. So we have this bold signal, right? The blood oxygen level dependent signal that you can observe when people are doing something, some activity. So you've got this little dip, and then whenever there's activity, it shoots up, and when the activity ceases, it goes down. Well, if you are doing something like a tapping exercise, it never drops all the way down to the x-axis. It stays up and it does this, right? You're tapping, right? So I thought, okay, how can I give these people the most bang for their buck when they're doing these neuroplasticity exercises? So I went over to Truvada's prescribing information and I looked for the Cmax value. Well, it's at 1 hour. So tenofovir disoproxyl fumarate reaches its maximum serum concentration at the 1 hour mark. Okay, so I tell everybody, take your pill, wait 1 hour, and sit down and engage in neuroplasticity exercises, because you are actually doing tapping exercises that are being measured, that are measured by fMRI. You're doing it at your house. So as you're sitting there, you're driving that medication into all those Brawlman areas when it's at its peak concentration.
Right.
And so I'm seeing improvements in that area. One individual, the first individual that took Truvada, did horribly on the serial 7. Took Truvada for 1 week, and after 1 week, I called her on a Sunday to see how she was doing, was able to successfully complete the serial 7. What's interesting about her too is that she had trigeminal and facial nerve, cranial nerve involvement. She had loss of sensation in her scalp, and she also had left-sided paresthesias. Both of those have resolved. There's an individual in Canada who experienced dysautonomia, and her resting heart rate is just about back to normal.
So this is all on Truvada, right? These are all patients that are taking Truvada.
Yes.
Do you know where else they're studying this? Do you know where anyone else investigating this? I know you said that some of those parts with the Chinese are involved in this. Do you know anywhere else in the States that's evaluating this?
In the States, I don't. There's a number of studies that came out of Europe. I'm on academia.edu, and all of my papers are actually on that site. But I have a list to a number of studies. They all.
Will you be able to share that? Can you email me that so we can put it in the show notes so that way people can take a look at it?
And every single one of those studies demonstrated a reduction in viral load in the individuals that received Truvada. The problem was it wasn't continued. Had it been, I'm sure they would be doing great right now. But that sudden interruption in treatment in therapy is the reason why we're having therapeutic resistant strains circulating. And if we don't watch it, we're going to be really up the creek because I can't think of anything worse than going into having a loved one who's given this therapeutic, right? And we're thinking it's actually going to do something, and they have a therapeutic resistant strain and they end up dying because of it.
Right.
And so
it sounds like we have a lot to do. And it sounds to me, just to recap everything as we get running through the hour here, because I'm going to have to wrap us up. The big picture is this, right? HIV and SARS-CoV-2 they rhyme. So their histories will rhyme. So to pay attention to what's coming with COVID and post-acute sequelae of COVID, aka long COVID, we need to watch long HIV. And one of the biggest issues, and where you're dedicating your efforts, which is fantastic, I can't begin to thank you enough for this, are towards the neurocognitive decline, right? The HIV-associated neurocognitive decline, and your myriad of articles and literature and identification out there now for SARS-associated neurocognitive decline, and you've created an assessment. You have your website. You're a software engineer, which means you can scale a lot of the things that you come across at Sandscan, S-A-N-D, scan.me. And you continue to do this research. You continue to dig. And the key here is therapeutics, right? You're going to have a therapeutic long term. And you have a couple candidates for that. So we do have some potential to mitigate when Murphy's Law strikes. So this is really good. In closing, do you have one key piece of advice you can give our listeners if they've been infected with SARS-CoV-2, or if they're struggling with neurocognitive decline with their HIV or with SARS-CoV-2? Is there any advice, just a quick tip you can give them as we close out?
I guess beyond what I've already talked about, I don't know. I guess raising awareness, doing what you can. I will say that I do a lot with criminal justice reform, bringing awareness to it. And I'm deeply concerned about what I've coined as first chair forgetfulness, and how the neurocognitive decline is going to impact the legal profession. I think it's important for people to
speak out, right?
Speak out.
Yeah.
Don't describe it as brain fog. Provide examples of your struggle. Tell people what it is that you do for a living, because things are only going to get worse.
Yeah.
There's no reason why anyone should believe that your neurocognitive impairment is going to resolve itself spontaneously.
Right. That I tell you what, right? That it's you're peeing in the wind, right? And this is the problem. So I want to thank you. I'd like to have you back on maybe in a few months to we'll do a little recap of where things have gotten, especially with the Truvada stuff, because that's really interesting. And I want to know more and want to hear more about your patient encounters with Sandscan. So Daniel Duggar, entrepreneur, researcher, board advisor for Vanderbilt's HIV research team, an amazing software engineer, who's from one of my favorite states, Tennessee. So thank you so much for being on the show. This is Dr. Murphy, right? Thanking you one more time, because guess what? When Murphy's Law strikes and you got a diagnosis, the treatment is Murphy's medicine. Thanks for listening and take care. Thanks, guys.